I'll just introduce you to a few of my friends, and with friends like these, who's these enemies, I have to say. And a lot of literature that you see in the scientific literature populated by maxillofacial surgeons is largely centered on how good you are as an individual or how busy your unit is. What NFORC can do is get rid of this tribalism. Everyone recognises this picture. I mean, it's Steve McCurry's famous Afghan girl picture. I think an absolutely beautiful picture. And I'm going to talk about injuries of this area. I want you to close one eye and hold your finger out and try and get your other finger to meet. Okay. When you've done that, let's put it apart again. Now open both eyes. Okay, and do the same. And you'll see that it's much easier with binocular vision. We need two eyes that basically form an image to give us depth perception. And the trauma around this area compromises that. Okay, so it has a functional problem. People say trauma is random, but if you look at the graphs, they're very similar. And we're talking about this column here. So every year, Chris and I do between us about 240, 250 cheekbone fractures with eye socket repair. This is somebody who's had a razor blade cut from ear to ear. So you have right eye and left eye socket. And you'll notice that there's a hole here, and it's difficult to fix. And we can mirror the normal side to the abnormal side, and then we can navigate using an expensive satellite navigator equipment that I won a charitable bid for, and navigate the reconstruction. But if you take the smallest fracture I could find in my library yesterday, this is from the side, and you can see the fracture here. And this is from the front, which apes the image you've just seen. And there is no core agreement on what size of defect and what size of position of defect on A, what material you use, we're getting better at it, and B, whether you treat it or not. That's important, because is Holmes doing 200 orbits a year who should be doing 20? And the answer probably is not, I hope. Or is he giving value for money? And we need to know that, and that's what NFORC is about. My heart goes out to Phil Hughes and his family for a terrible injury, all those who saw the news yesterday. And we've studied people who've been hit from the front with base of skull fractures, and people who've been hit from the side. And when the poor cricketer turned his head, he got hit from the side. And you'll see the fracture propagation is much more around the bits of brain that really matter. If you smash this part of your brain up, you simply behave a bit odd. If you fracture this part of the brain, you don't do very well. And we know that patients who have that lateral vector do have a higher instance of needing neurosurgical intervention, have a higher instance of bad outcome. And that explains why this chap that you see a before and after, so the rotating skull, hopefully, is the before. And he was so badly smashed up that his top teeth didn't meet and the fracture went from here to here. This explains why this gentleman had a cup of coffee in recovery half hour after the surgery, and why we never got to this patient who was hit from the side. Okay, equivalent forces, different vectors, research, outcome. But we don't know how the anterior skull-based people behave. We also want to be able to target people so we can get the patients day one, the waiting list for rehabilitation. So trauma research, I think we know what to do most of the time. We need to refine what we're doing, and you can't do that in a test tube bottle. You have to do it with the patient population. And what ultimately matters is happy patients, right treatment, right time, every time.
This is absolutely brilliant, creating the world's first ever research centre dedicated to this most socially sensitive part of our body, which will collect major data and organise research to improve patient treatment worldwide. Well done, Saving Faces.